All right, what's up, everybody? Sorry for the technical difficulties for PT on Ice this morning. My name is Ryan Smith, first of all, and I'm going to be talking today about Mechanotransduction, the science behind the sermon. I'm the COO of Recharge and Hoko CrossFit, which is a combination CrossFit and physical therapy, fitness, and wellness center in Ellicott City, Maryland. I'm also one of the lead faculty with Mitch Babcock and Zach Long in the Clinical Management and Fitness Athlete Division of the Institute of Clinical Excellence. So, again, sorry for the delay. Let's jump right into what we're talking about today, which, as you can see by the title, is Mechanotransduction. So let's define this quickly, because I'm describing it as the science behind the sermon, right? So Mechanotransduction, what we're looking at, is really addressing the question of how precisely does exercise promote tissue healing? How do forces we apply on the body actually affect the cells at a physiological level? So if you go to any of our courses or take our online course, our sermon to the physical therapy profession as a whole is that we drastically underload our patients, that we do not challenge them enough to get the proper adaptation that we need out throughout their life. A great example that I like to look at is how we approach postpartum women, and that their child, who weighs anywhere from 6 to 12 pounds in a baby carrier, is somewhere around 20 to 25 pounds, and they're hauling that day in and day out. And yet you are telling them that they need to sit on their back and do clamshells or light, 3 or 4 pound weights, is not matching up to the load that is demanded of their life, right? So all in all, that sounds really great, and it sounds a lot like bro science a little bit in terms, but we now are starting to begin to get a clearer picture of the biological underpinnings, and that's through the understanding of mechanobiology, mechanotransduction, and then how we use that exercise and movement and prescriptively as mechanotherapy. So there's 2 major papers on this I want you to consider, and then a theory that comes out. So back in 2002, Mueller and I think it's Malouf is how you pronounce it, or Malouf, proposed the general physical stress theory that broke up into, okay, how are we actually stressing the system with exercise in different ways to categorize it. The papers that have come out recently have been Karim Khan through BJSM, about mechanotherapy and mechanotransduction, the difference between the two, and most recently Sharon Dunn's paper on mechanotransduction and its implication for physical therapists. So those are the 2 we're going to be highlighting here. What we want to start getting you on the train of thought of thinking is getting a deeper understanding of this. Of when I was a student, I saw everybody get 3x10 sets and reps for everybody. I think we underloaded every single patient I was ever in the clinic with, at every clinical I was at, and everywhere I saw and observed. But we always told the patient they're getting stronger. You're 3 out of 5 on your whatever manual muscle test, but we need to get you stronger. Or, you're tight, so we need to get you more range of motion. We need to get you, more mobility, etc. And I always said was, let's get you stronger, without ever understanding what we were talking about, right? So this is the underlying principle behind it. So at a biological level, our current understanding is that these cells that have cytoplasm, right? If you remember from your 5th grade biology of the circle with all the cytoplasm, and that's where all the organelles were for the cell, that it has an a cytoskeleton of sorts that senses, responds, and even generates force between cell to cell, right? So it responds to forces on the cell because it has a cytoskeleton that surrounds basically that cytoplasm that we're looking at, right? It also responds to the stiffness of the cell. So everything we're made up with is able to respond to mechanical forces applied to it, and from there generates a response at the cellular level, right? From creating proteins to DNA synthesis, all that is responsive to mechanical forces. So when you do a goblet squat or a deadlift, the forces that are exerted on those cells are responding to what you're doing and are attempting to adapt in a certain particular way. So you have mechanical trigger, you have cell-to-cell communication, that not you're just doing a deadlift and promoting one cell in your glute, it's communicative throughout all of them, and then you're getting a response at the cellular level, right? That's the basic understanding of what we're talking about in terms of mechanotransduction. Mechanotherapy being applying an exercise to get a specific adaptation. Right? That's the biological underpinning. And what they're starting to find is that we're having responses of certain proteins or certain DNA sequences that are coming out from that, and cellular responses that are predictive, right? That we now know. The easiest one of this, for an example, could be of a mechanotransduction thing is, the hair cells, right, in your ear. They respond to sound when they're waving, right, and they convert those sounds to action potential waves, which is really, really cool. But we have that in all different types of tissues, whether it's endothelial cells in our blood vessels that respond to constant blood flow and blood pressure that adapt over time and then have implications for atherosclerosis, whether it's the epithelial tissues in the lung tissues, right, that respond to immediately after birth. We take that first grasp of air and they start developing and responding to constant breathing, and over time can as well. It can be osteocytes that we're probably most familiar with, the bone adapting, such as Wolff's Wall over time. And then we have chondrocytes in the cartilage, etc., etc. There's a bunch of different types of cells throughout all the tissues in our body that respond to mechanical forces. And we're starting to understand the biological underpinning to that and seeing a sequence of events, which is amazing. And it can allow us to stop guessing of what we're doing, stop throwing 3 by 10 and say, hey, get stronger, you'll feel better, which we have no clinical implications for, and starting to understand how do we get the adaptations we want. So that's really awesome. In the Karim Khan paper, they mentioned a few studies of looking at different ways that mechanical forces are applied and how it responds to tissues. For one, it was the eccentrics on tendons and showing a normalized structure of that tendon, right? They looked at hypoechoic areas and overall collagen structure for that and saw changes over time with the actual physical structure based on eccentrics. They looked at continuous passive motion where somebody is just passively moving somebody else for osteochondral defects in the patella after, I think it's a periosteal transplantation, and somebody just moving the person itself. And they saw positive outcomes of that type of mechanical force itself. And then last was just intermittent compression underneath a cast for distal radius fractures that also saw positive outcomes with that type of movement from the mechanical force. So that goes into our biases a little bit, right? Of it's not just exercise. Sometimes it's mechanical force from somebody else moving you or from actual intermittent compression of the cells themselves that can cause a positive adaptation potentially. Now the kicker for that of like, okay, I might be jumping to manual therapy might have positive implications of actual mechanical forces. Well, possibly, but both those groups were at a very, very low capacity level for those tissues. A radius fracture that's immobilized is probably going to respond to any mechanical force you apply to it, hopefully in a positive way that doesn't exceed its capacity. Continuous passive motion after a transplantation of the periosteum in the patella is probably going to respond well to continuous passive motion. What I think these studies are saying in that article is that we're getting to the point that we know that mechanical force has an effect and an adaptation in the body, and we need to be the experts, the movement experts, at being able to assess somebody, determine where their tissue capacity is at, apply a certain amount of mechanical force through exercise to get where we need to go. We are done guessing. We are done using 3 by 10 on the plinth and doing whatever sort of work you want to do. I get really passionate about this in the live course and talk about, your soccer player that's coming back and has knee pain and you're having them do straight leg raises when later that afternoon they're going to be doing 60 minutes of cutting. It makes no sense that your loading in the clinic does not exceed the loading at practice. You are fundamentally a chronic rehabber if you do that, and you are preparing that athlete or that person or that patient to not be able to meet the demands of their life. This is the science now underlying this as we get more specific, right? So all in all, what I'm trying to get at is that as clinicians, with this biological understanding, we can be more exact about how we're trying to describe this. This understanding of mechanobiology is still very new in the field of science, relatively speaking. And we need to start considering that as we learn more, we can become have more expertise in this area of how we specifically load. So we can start looking at load in types of quality in terms of the tension of load, compression or shear force that comes through, and how those 3 different types of forces can affect different groups of people, like power lifters versus Olympic lifters might respond different compression versus shear. We can look at the peak rate of loading. So when someone jumps, how much load is on someone's tendon, of their patellar tendon when they jump versus when they do a tempo pause squat and create tension through that. So that can look at the rate of loading, the speed of it. We are starting to find that patellofemoral pain responds differently to pure volume, and patellar tendinopathy responds different to more slowing down eccentric and tempo exercises. And if you can assess and differentiate between the two, you can have more success with that person who's coming in you with just knee pain. Or it could be just simply looking at volume. So either at the peak rate of loading, the peak of loading, the rate of loading, or the volume of loading. All different variables we can look at that keeps people moving, but we do that in response. Now, all in all, it looks very, biologically speaking, very mechanical. We have to, in the context of patient care, we understand this person is complex. And their perception of loading, their perception of what you're putting on them, also plays a significant role in addition to if they're in pain. If they're in pain, it can transfer and differentiate where those forces are going through the body based on the muscular response. So it's a very complex idea, and their perception plays a role in this overall biomechanical understanding of this. So all in all, we need to start establishing ourselves as actual movement experts. Right? Mitch and I talk about owning your kung fu, actually learning and feeling and doing these movements. But the other part of this is starting to get a better understanding of the biological mechanisms behind this so we can be more exact in how we load people. And it starts with the idea of mechanotherapy and how we begin to apply that in our critical reasoning and assessment of the patients in front of us. And realizing that when we apply load, it's to a complex biological individual in front of us that is going to be different from person to person, and we need to become the experts at how we load people, how we determine their capacity, and how we get positive adaptations over their life that keep them moving. Because that's the ultimate goal. Anything passive is not going to get us the adaptations we need to help them meet the demands that we want for people to keep moving throughout their entire life. We need to get them as active as possible and be able to apply a load that helps them meet the demands. All right. Again, sorry for the delay. I'm going to rattle through the quick courses we have going on. At Recharge, we have Jeff Moore coming on December 16th and 17th for the cervical spine course. I know we have the clinical management of the older adult starting up in January 14th, and those are just two I wanted to highlight as those start coming out that relate to where we're at. The full list will be published here soon. So again, thanks for watching. Mechanotransduction is the word of the day. It's not just a buzzword. It's an underlying biological mechanism you need to understand if you're going to be an expert clinician. Thanks, guys.